Hi, this is Jennifer O'Brien, Section 1, Term 2. I am in my bedroom preparing my primary and secondary infusions. First thing I'm going to do is look at my MAR and review the orders and make sure my patient doesn't have any allergies and review their medical history. It looks like we have an order for normal saline as a primary and a flagyl diluted in normal saline as a secondary. So I'm going to do my math, which comes out to 33 drops a minute. Actually, to 33 drops a minute for both. So that's a nifty coincidence. I'm going to review my med card. It looks like that is a safe dose and a safe infusion rate, so we're good to go there. I'm just going to have to make sure for those side effects after I use it. Then first things first, I'm going to go ahead and drop my saline flush for the primary. Trash. About 6 milliliters for my flush. Make sure there's no air bubbles. And if you're in the hospital, I use some Chlorlock, but we don't have that. So I'm just going to close my sharps, put this back in my sterile container, which this one will still be sterile. And then I'm going to take my primary tubing. And since it's just normal saline, it doesn't need a label on the bag. I'm going to go ahead and take the cap off of this. It'll still be there. Stab. Prime. And then either over a sink or trash can. Run it until it's primed already in. Which already is. Alright, now that's prepared. It's the cap's still on, it's still sterile. Go ahead and put that on my tray in my patient's room. Make sure I have a label to label it when I'm in there. Then I'm going to move on to the secondary bag. First, I'm going to have to draw up my medication, which is 2 mils. Make sure there's no air bubbles. And once again, we don't have the locks, so I would lock it like that, and the lock would still have this to be sterile. Then I'm going to unfortunately I have an old bag, so inject the medication, toss my sharps, shape it up, and then I would label it with my client's name, date, my initials, the drug dose, and then the time once I put it in there. So that's ready. Now I'm going to prime that tubing as well. Now that's fine. So I'm going to take my MAR, my medications, my flush, and go in my patient's room. Alright, now I'm about to be walking into my patient's room. I'm going to knock on the door. My patient already knows who I am from the first time. Alright, I'd ask them to verify their name and date of birth. Then I would review my MAR and confirm with the patient that they don't have any allergies to any antibiotics, and then also see if they have a history of having had antibiotics before and if there was any reaction to them. My patient, no allergies to antibiotics, and has had them before with no adverse reactions. So the first thing I'm going to do is tell them that what I'm going to be doing is being primary and secondary. Then I'm going to inspect the IV site to make sure it's still no signs of infection or infiltration or anything like that, which it's not. It's completely free, not red or swollen, no heat. Then I'm going to, for the intent of this video, I'm going to go ahead and do both my secondary and primary together. So there's going to be things I'm going to have to state instead. But first, I'm going to cast on my gloves, preferably bigger than these ones. And then I'm going to flush and make sure that it's still patent. So I'm going to aspirate for a blood return after I unclamp it. Oh, that's the one, which is a great sign. Flush, push, stop for 3 milliliters. Everything seems fine. So I'm going to reclamp it for now. Take off my flush. Toss it back in its sterile container. I would have swabbed that before I flushed it. And I'm going to take my normal saline, which would be my primary. Swab it again, just in case other bacteria has been introduced. This one is still sterile because it's already been, or it's still capped from the first time. This would be a clean one since I'm port full. Toss that away. Go ahead and connect it. This would be, unfortunately my tape is not working very well in these dummies. That would still be where it was. And I'm going to establish my flow rate, unclamp the INT, drop going, unclamp this, both sections. And this is where I would adjust the flow to 33 drops a minute. Good. Now we monitor the site for any signs of reaction to the antibiotics or infiltration. Everything's still good. And then if I was discontinuing this, I would wait for it to run its course, and then I would flush it again using the push start method again with another 3 milliliters. And depending on hospital policy, I would use the heparin if ordered by the doctor. But for sakes and purposes of this video, I'm doing secondary and primary together, so I'm going to go ahead and go in there. And I'm already in here, already asked him about his allergies to antibiotics, so now we're going to start the actual antibiotics. So I'm going to start by lowering my ceiling. Got that lowered. Hang with secondary. Now I am going to, since this is already running, I don't need to worry about flushing anything. So what I'm going to do, since this has been exposed, I'm going to go ahead and swab that before I connect to my secondary. Toss that in the trash, like this, and then go ahead and, if the clamp had been above the secondary port, I would have clamped it off, but on our lines they are not, so there's no way for me to do that. So they're both going to be running. I'm going to unclamp this, and then I would adjust the drops to 33 drops a minute. Now, then I would consistently come back and check on my patient while they were both infusing, make sure they had no reactions to it. Then after they were, and before I would leave the room, I would label both sets of tubing with the date, time, my initials. Bags are already labeled. And then I would document well, I would do some more, first of all, and then I would document the date, time, the dose administered, the route, and then obviously the condition of the IV site is still good, it's patent, no infection, redness, swelling, no coolness, and I would, after completion, I would document the amount of fluid volume on the MAR or the IMO and or the IMO record, depending on the patient. And that's it for this. Alright, I'm Jennifer O'Brien. I'm going to be inserting an NG tube today. First thing I would do would be to check my MAR, which says that you're going to be inserting a 12 French NG tube per section. Then obviously I would tell the patient what was going on, we're inserting it, and then I would ask them if they had had any nasal surgeries or broken their nose at any time, and I would talk, I would look, make sure there's no deviated septum, check their mouth and throat, make sure it's clear. Then I'm going to take my tube and measure to see how long it should be to go into their section, to their stomach, from the nearest nose to the ear, the xiphoid process. And then I'm going to mark it either with tape or marker. Love it. Then I'm going to take my tube to about 4 inches. Right? And I would tell my patient it's about to begin, please lean your head all the way back. And all they have to do like that, would start to insert it about 4 inches. And then I would recheck to make sure there's no coiling in the back of the throat. Make sure that it's still going. And then I would advance. And then I would ask them to lean their head forward to their chest. And then I would continue to insert it until I got to my mark. And at that point, I would put a temporary anchor in a piece of tape. Okay. the best way would be by chest x-ray, but I would also ask them to speak. Like I said, I would check for coiling again in the back of the throat. If there's no coiling and no trouble speaking, and I would aspirate for gastric contents. I'd aspirate back about 30 milliliters or so, and it would be yellowish green. Look for the consistency, and this would be where if it was part of my hospital protocol, I would test the pH, but it's not. So I would get ready to re-inject it, listening for a swishing sound with my stethoscope in the left upper quadrant. Alright, I hear the swishing sound, and I got gastric contents back, so we verified the placement. It's in the stomach, not in the lungs or anything. So then I would take off the temporary anchor. I would go ahead and anchor it to the nose instead. I would not be that. And then brace it across the bridge of the nose as well for extra stability. Alright, and this would be the point where I would make sure to a little bit of leeway. Alright, and then I would tell the patient not to jerk at it, try not to move too fast, and to make sure not to pull it out. And then that's when I would attach it to suction at low intermittent suction, according to my mark. And then I would go back and I would document the time of the insertion, obviously my initials, and the size, reason, patient tolerance, and that's about it. And then I would let the patient know that we would be coming back every couple hours to perform oral care. Obviously I would be checking in on him working that, and that's about it. Alright, now I come back, and it's time for me to irrigate his NG tube. First thing I'm going to do is implement standard protocol. I would put on my clean gloves.
Document the pH that I tested.
I'm going to check the placement. It doesn't look like it's moved from the baseline mark that I put on it when I first inserted it, so that's good. And then check the placement. First thing I'm going to do is disconnect the section. Just in case. I'm going to aspirate the gastric secretions. I would look at the color consistency again just to make sure. And then I'm going to listen to it just like I did the first time. Yep, I still hear the swishing sound. So then that would be when I would irrigate it. So I'm going to inject it, and then after I inject it, aspirate slightly, and then it should push back on its own, whatever I got, and then I would hope to get the same return that I injected, but if I were to get more back, then I would know there's some residuals in their stomach for some reason, maybe a blockage, maybe they're just not digesting it how they should be, and this I would not re-inject. I would disconnect this and dispose of it either in the toilet or basin. Alright, and then I'm going to reconnect this to suction. And that would be it. And then I would document how much I irrigated, if I had any backflow other than 30 mils I inserted, what kind of fluid I used to irrigate with, the time, date, and that's about it.